Assalamu alaikum. I am Dr. Afroza Akhter, working as an assistant professor at Institute of Nuclear Medicine and Allied Science. Welcome to all of you in my presentation. My topic is transforming skeletal metastasis diagnosis, precision with hybrid SPECT-CT over conventional whole body bone scan. We know that accurate detection of skeletal metastasis is crucial for cancer care. Conventional bone scan remain a convenient and standard imaging approach worldwide because it is the most common screening test. It has the ability to scan the entire skeleton and also the high sensitivity and of course availability and low cost. However, there is lack of specificity because all that hot uptake are not metastases. They can be benign and it varies according to the degree of tracer avidity. So there is a question, and in our study include the solitary lesions or equivocal uptake on planar bone scan because the solitary lesion can be metastasis, can be suspicious or can be benign. So we need further imaging technique. Before that, I want to mention that there are some key consideration for SPECT-CT in nuclear medicine. First of all, for nuclear medicine physician, then for referring clinicians need, and of course the patient priorities. For nuclear medicine physicians, need to expand the SPECT-CT use where it adds the diagnostic value, especially in challenging cases, and no SPECT-CT for straightforward cases like multiple metastases. For the referring physician, we need to provide a clear, definitive answer. That means benign or malignant. And of course, accurate and early diagnosis to smooth the patient's pathway. Now, the aim of our study is to enhance the diagnostic accuracy of skeletal metastasis detection in cancer patients with solitary or equivocal findings on technetium MDP planar bone scan. Objective was to evaluate the impact of SPECT-CT by combining functional and anatomical imaging, differentiate metastatic from benign skeletal lesions through precise localization and characterization, and achieve the superior diagnostic accuracy through SPECT-CT and optimal cancer management. Our study population included total 50 patients and include diverse primary cancer. Most of them are prostate cancer, breast, and lung cancer. Inclusion criteria was solitary or equivocal or suspicious uptake on planar bone scan. Our imaging modality include Siemens Symbios SPECT-CT gamma camera machine, and further correlative imaging like MRI or cytological report are also analyzed in available follow-up cases. This is the imaging technique of planar bone scan and SPECT-CT. First of all, we inject 20 millicurie of technetium MDP IV. Waiting time is 3 hours. Then we took full body planar bone scan, acquisition time about 15 minutes. Then in the same sitting, we perform the SPECT-CT, 3D SPECT-CT acquisition in the suspicious cases, that means for solitary or equivocal cases. CT acquisition time takes 2 to 3 minutes and there is automatic SPECT-CT fusion reconstruction. In our study, among the 50 cases, SPECT-CT classified 25 cases as metastasis and 25 cases as benign. That means 50% metastasis and 50% benign cases are excluded in our study. Among the SPECT-CT positive metastatic cases, mostly are osteoblastic lesion, that means 52%, then mixed osteoblastic and lytic lesion 28%, rest are osteolytic metastasis and osteoblastic metastasis with degenerative changes. Among the SPECT-CT positive benign cases, mostly are degenerative changes, that means 44% are degenerative change, that includes vertebral end plate sclerosis, bridging osteophyte, osteoporotic compression fracture, scromal knot, and asymmetrical arthritic changes. Now I want to show some representative cases. In the planar bone scan, there is a focal tracer uptake at the 6th dorsal vertebra. Then we perform SPECT-CT in the region of interest, that means in the chest. There is a solitary osteoblastic purely sclerotic metastatic lesion at the 6th dorsal vertebra in a 75 years old male patient with prostate adenocarcinoma. In our next cases, there is a focal radiotracer uptake in the L3 vertebra on the planar bone scan. SPECT-CT imaging showing there is a sclerotic lesion arising from the posterior aspect of the vertebral body in a 70-year-old male patient having adenocarcinoma of prostate. The next case is a 70-year-old male patient with prostate adenocarcinoma showed focal radiotracer uptake in the uh, focal radiotracer uptake in the planar scan on L3 to L5 vertebra on planar bone scan, and SPECT CT shows marked degenerative changes and end plate sclerosis in the fused images. The next case is there is a focal radiotracer uptake at L3 vertebra in the planar scan, which corresponds to osteolytic lesion with marginal sclerosis in SPECT CT fused images in a 50-year-old male patient having esophageal cancer. The next case, a 40-year female patient, known case of CA right breast, post-surgery and post-CTRT status, showing focal radiotracer uptake at the manubrium, which shows arthritic changes in the sternoclavicular joint in the SPECT CT fused images. Next, focal uptake, which was not clearly visible in the planar scan, but SPECT CT demonstrate osteoblastic lesion in the left 6 rib. Another focal uptake at the left sacral ala corresponds to osteolytic and osteoplastic lesion. The next case, a 50-year-old male patient with history of left-sided radical nephrectomy due to renal cell carcinoma, showing focal increased radiotracer uptake at the left pubic bone and acetabular region, which corresponds to predominantly osteolytic metastatic lesion in SPECT CT. The next case, a 40-year female with CA breast patient showing osteoblastic activity at the L2 vertebra with polka dot appearance on CT representing vertebral hemangioma. That means a benign pathology take up the tracer. The next case, a 56-year female with CA right breast patient showing focal increased radiotracer uptake at L4 vertebra, which corresponds to the bilateral facet arthropathy or degenerative changes. These are the most common confusing radiotracer uptake in the planar bone scan. That means degenerative change or facet arthropathy. The next case is another interesting case is planar bone scan showing extraosseous uptake in the epigastric region, and on SPECT CT we found that there was metastatic hepatic metastasis which was calcified and uptake on SPECT CT images, and bone scan was negative for osteoblastic metastasis. So there is some limitation. In our study is a retrospective study, sample size was very low. And another question, what modality is the gold standard? Sometimes MRI is better, CT scan is better for cortical imaging, and MRI is better for marrow imaging. And of course, there is a additional radiation hazard because, we always give it intention that if a patient can take same session imaging, it can be beneficial for patient. On SPECT CT acquisition protocol, usually 4 to 5 millisievert for a typical administered activity in bone scan, and we use low dose CT scan which 1 to 4 millisievert. And of course, training is necessary for SPECT CT imaging and awareness. These are some reference articles which we use in our study that shows that differentiation of benign and metastatic lesion by SPECT CT image has superior diagnostic performance and diagnostic confidence over planar scintigraphy. In conclusion, SPECT CT bridges the gap by combining functional and anatomical imaging, offering reliable differentiation of metastatic and benign lesion, uncovers incidentally clinically significant findings, provide a patient-friendly one-stop imaging solution, and of course, slightly higher radiation dose but cost-effective and highly precise. It reduces the false positive result and improves the reporting quality. Thank you very much for giving me this opportunity to present here.